All right. So of course, I'm working from home and they're mowing the grass. I've been saying all this grass. When are they going to come mow the grass? Come on. When are they? So if you hear noises, that's what it is. It's like of all days. So hello, everyone. I'm so excited to see everybody. Oops, what did I do? Okay. So I'm hopefully going to do this correctly. Elizabeth, if I don't, maybe you can help me out. There we go. Oops. All right, where am I? Oh, this darn, the
It's
taskbar is covering everything again.
I know
So,
I hate that.
so then I have to move it. And I don't know why I'm starting. Here we go.
All
Let's start
right.
slideshow. Oops, there we go. Right, am I doing this
Yep.
correctly?
And
Okay.
then you can
All
go
right.
ahead and do it from the beginning or from current slide, whichever you want to do. I would just do it from your current slide. You can go back
Okay,
and forth that way.
here we go. All right, got it. All right, so today I'm presenting on attention deficit disorder, hyperactivity disorder, or trauma stressor, or PTSD, variety acute trauma stressor, right? And one of the reasons that I have such an interest in this area is that over the 25 years of practice, it's actually more than 25, but I just keep it at 25 now. So over 25 years of practice, um, and working in outpatient, working in inpatient, working in the school system, I saw so many kiddos who were diagnosed with ADHD. That was like the first go-to, but who had a significant trauma history that was never addressed clinically or addressed with fidelity. So, and these kiddos were on lots of medications, right? And the nothing is working. So part of that I think is due to the um, lack of assessment, I think, for trauma and in the kiddos that we work with. So that was what initially got me involved in this kind of area and looking at this area for research and just to become more aware of for my own, personal practice. Um, and I had worked at a school, the highest restrictive level school in Palm Beach County, and I had 15 to 17 kiddos, and I would say a good 12 to 13 of those kids had the history of trauma with no not being addressed in any way clinically in the past. So, all right. So how do I? Oh, there we go. Okay. All righty. Is that the? Sorry, guys. I'm not really good at this stuff here, so I think don't know if I'm going in the right direction. Shucks. Nope. Okay. Not that far. I
Just go
know.
to your air. Yeah, just do your arrows left and right can work too.
Okay. So if I need to go back, I go to the left.
Hmm.
That's going forward. Okay. Is it opposite on mine? Of course it probably is. I don't know what I did. So how did I get out of this? Here we go.
Just
Okay. We're at the end. All right. Questions, comments? Thank you.
no worries. Here. Do you want me to take over?
Yeah, thank you. I'd
Oh,
appreciate it. I don't know what I did.
it's
So I
okay.
stopped sharing. Okay. Thank you.
All right. Just tell me next slide whenever you're ready to do it.
Okay.
And that's not
Great.
a
Thanks.
problem. Oh yeah, of
I
course.
appreciate it. Okay. Oh, that was the next slide. So, okay.
There you go.
There we go. So, I'm preaching to the choir with all the diagnostic criteria, right? Looking at attention deficit hyperactivity disorder. We see patterns of inattention and hyperactivity, impulsivity. This interferes with functioning or development. The inattention is often fails to pay close attention, difficulty sustaining attention in non-preferred tasks. I want to make sure I say that because I have a lot of parents who are like, oh, but they can focus on their video game, for hours. And it's like, well, yes, because that's a preferred task. It's a little bit easier for all of us to do that. And they don't follow through on instructions, difficulty organizing. They dislike or reluctant to engage in tasks that require that sustained mental effort, or if it's a non-preferred task, they lose things, and they're distracted by extraneous stimuli easily and forgetful, right? So next slide, please. Thank you. So the hyperactivity piece of this, they fidget, they tap hands, they leave seats when they're supposed to remain in the seat, which I think they should be able to, stand up if they need to, but often run or climb in situations that are inappropriate, unable to engage in play or leisure activities. And this one is common phrase that I hear, often on the go as if driven by a motor, right? Like the little race car that we often talk about, talks excessively, blurts out answers, often has difficulty waiting turn, and often interrupts and intrudes. And when I look at this list, I can think of even myself when I was little because I always got the talks excessively and I got in trouble for that. But so these are the kind of the criteria that we look at for ADHD. And then the next, I'm going to look at the criteria for PTSD or trauma stressor, the general criteria. So next slide, please. Thank you. So the kiddo has to have exposure to threatened death, serious injury, or sexual violence. Now, this can be different for every person. Something that may be traumatic to me may not be traumatic to Elizabeth, right? So it's a very personal experience. But with this, we see like involuntary and intensive distressing memories of the event, sometimes dissociative reactions, prolonged psychological distress, and sometimes physiological symptomology as well. So with that, we have irritable behaviors and angry outbursts, okay? Reckless and self-destructive behavior, hypervigilance, exaggerated startle response, problem with concentration, and sleep disturbance. I'm gonna let Mandy in. It's on my screen. Okay. Okay. Next slide, please. So we know through the literature, and this is from 2017, so it could even be higher than what's presented here, that 1 in 4 of US students have witnessed or experienced a traumatic event before the age of 4. That's significant because that's during that time, that 0 to 5, where we're learning to trust the world around us. We're seeking to get our needs met. Hopefully they get met. But a lot of times they don't. And many of the kiddos that we work with have experienced significant trauma from child physical abuse to sexual abuse, and neglect as well. Okay, so we know, and again, I know I'm preaching to the choir here, but I'm just reviewing this, that a kiddo exposed to trauma, they have a lower threshold for stress, right? That amygdala is like on fire all the time, and they're just ready to, to fight, to flee, to freeze, to please, whatever their mode is, they go right there when a stressful event happens, okay? And the developing brain, as we know, this is from Flannery, but we also know from many other research sources that the brain can actually be changed, right? A developing brain can be changed by trauma exposure, and memory and regulation of emotion and development of language skills are impacted. So we see a lot of kiddos who present to us with speech delays, that could just be from a language development aspect, or that could be from experience of trauma, or lack of exposure as well. So kiddos who have been abused or exposed to violence, they are more likely to be in special education, have test scores that are below grade level, demonstrate poor executive functioning, which impacts work habits, and are 2.5 times more likely to fail a grade. And then we have, now this is Dr. Swagger may have a more updated percentage of kiddos with diagnosed with ADHD, but 21.7% of kids in the United States are diagnosed with ADHD. So we're looking at 1 in 4 kids have experienced trauma, right? 21.7% of US kids are diagnosed with ADHD. So keeping those numbers in mind. Okay, thank you. So I'm just looking at the comparison, right, of the symptom presentation. Irritable mood, okay, reckless and self-destructive behavior, the hypervigilance, exaggerated startle response, problems with concentration and sleep disturbance. We see it with kiddos who have difficulty waiting turns, right? They interrupt and intrude on others, often unable to engage in play, right? Quietly. If they're driven by a motor, I know I've said these things before, but I think it's important to kind of look at the two and make the connection. Um, and difficulty sustaining attention and does not listen. We see this in both kiddos who present obviously with symptoms of ADHD and PTSD or a trauma stressor, like acute trauma stressor. Okay. Next slide, please. All right, so we can see the overlap here, right? The overlap of symptoms. Different symptoms on the outside, but definitely an overlap that the difficulty concentrating and learning in school, easily distracted, often doesn't seem to listen, disorganization, hyperactive, restless, difficulty sleeping. Okay, so that's the overlap that we see with these two diagnoses. Okay. Thank you. So with this, and please, anybody jump in at any time if you have any comments or questions or anything. I think that, again, from the perspective of a clinician, and then we also have doctors and we have, other providers in this audience, that understanding that a kiddo who looks like, oh yeah, they have ADHD, or they come to you with a diagnosis of ADHD, but nothing seems to be working, right? I have a kiddo that I'm seeing now that he was being seen like for behavioral therapy, specific behavioral therapy at CRC, and it wasn't really connecting or working for him. So then I started seeing him and then discovered there was a significant history of violence in the home, continued exposure to violence. So even though he did present with symptoms of ADHD, he definitely had those trauma symptoms as well. So this is a vignette. And I thought I'm going to go ahead and read it, or everybody can. You want me to read it, or everybody can read it? It's bigger on the screen than I thought it would be. So I'll go ahead and read it. Okay. Jack Henderson's third grade teacher had been noticing that he has difficulty concentrating in the classroom. When she mentions this to Jack's mother, she reports that he also struggles with following instructions for completing chores at home. So that looks like, right, not being able to follow directions, not being able to focus on what's being said. Okay, during a parent-teacher conference, the teacher says that she believes Jack is displaying signs of ADHD. Jack's mother discloses, however, that his difficulty with concentration seemed to appear after a series of sometimes violent family conflicts during which his father struck him and his mother and subsequently moved out of the house. After moving out, Jack's father was injured on his construction job and ended up hospitalized for an extended period. So does Jack have ADHD, or might he be showing symptoms of traumatic stress? Or could it be both? So I just wanted to see kind of what everybody's thoughts are on that. If you wouldn't mind joining, either just, unmuting or putting it in the chat. Anyone?
Yeah, please feel free. We want interaction, so feel free to unmute and chat. Or you can even say, I don't know.
Exactly.
You bring up a point that I always struggle with is could it be both?
Yes.
And I really struggle to help kind of piece that apart. And I feel like sometimes that's where I review a lot of forensic evaluations of kids that are now looking at out-of-state placement. And Dr. Swagger and I have had this conversation numerous times, but evaluators really like to be able to give ADHD or depression or oppositional defiant disorder or conduct disorder, and they'll mention that their kid has experienced trauma, but there's very little tie-in in their evaluations to how the trauma could be affecting the symptom presentation. And then we know it then affects what placements will take them and everything. So yeah, I struggle with could it be both, and that and how we piece that apart.
No, exactly. And it absolutely can be both, right? And then if a child truly has ADHD and they have the trauma exposure, their symptom presentation is often escalated, because they're experiencing both. So it is hard to tease out. And I think that goes back, well, I'll talk about it in a couple of slides, but, the assessment piece of this and really getting like all of the information that you possibly can about this kiddo in all different environments, right? Because for example, if he's acting, this way, say Jack is doing this only at school and not at home, or only at home and not at school. So looking at the environments where Jack is presenting this behavior will tell us something as well. But that can also mean, yeah, he does have ADHD and it's exhibiting, but he's exhibiting this in school and also at home. But typically, if we're just seeing the behavior at home, then most likely we can kind of lean more to, that it's more of a trauma related disorder or something within the family context that's happening. But so I think someone mentioned trauma. Oh, Angela. Okay, thank you, Angela, for responding. So you think it's trauma? Do you want to say a little bit about that or not? It's okay.
I guess just sounds like he has some trauma, but you're probably right. It could be multiple things.
Mm-hmm. Okay. Yeah, so it can be. Go ahead. I'm sorry, dear.
I think they're good with just echoing, but yeah.
Oh, okay. Okay. Very good. Yeah, so it is. So I think this is a great example of like how difficult this can be. And how we really need to explore as much as we possibly can in regards to all the different environments that these kiddos are in. And sometimes, um, yeah, yep, I agree. So Dr. Swagger said there's really need for more in-depth exploration. This is surface level, dig deep. Yeah, and that means, well, I'll go ahead with the next slide, sorry. Okay, again, looking at ADHD and trauma, right? So kids who have ADHD are more likely to experience peer victimization, right? So then that can create trauma for a kiddo who has ADHD already, and that just exacerbates all of the symptomology, right? ADHD women are more likely to experience victimization, okay? More likely to develop PTSD, higher prevalence of PTSD within ADHD. I like this one, ADHDers, like it's a whoo group. Um, so ADHD is associated with a higher rates of traumatic experiences, and due to less flexible nervous system, ADHD bodies have a harder time regulating after stressful events. I would argue with that one that both kids who have experienced severe trauma, because they're always in that hyper vigilant state, that they also have a harder time regulating after stressful events. So, okay, next slide, please. All right. So how can we help as a clinician, right? Just like, Dr. Swagger concurred with the complete and thorough assessment, which includes information from school, from home, from if they attend daycare, before or after care, the grandparents, if they go there a lot. As much information that you can possibly obtain will allow for a more clear and descriptive diagnosis for this kiddo. And sometimes, and Dr. Swagger might want to chime in on this one, sometimes medication for ADHD helps to rule out, right? Because if you're treating with ADHD, you've tried a couple medications, different medications for it, and I know that, that it can take a bit, it's a trial with ADHD medications, but after you've exhausted your trial, if that's still not, if the symptoms are still presenting, then most likely it's not ADHD and it is, a PTSD or a trauma stressor. So that medication sometimes can help us rule out if
Oh.
it's truly no.
I'm going to rephrase that, Kelly, because
Okay.
I do not, this is just complicated. I really don't like the idea of med trials to rule things out. That's
I
really,
wasn't suggesting it.
I know, but I want to make sure people don't hear that. But it's also
Okay.
complicated, right? Because some of the ADHD medicines, like your alpha 2 agonists, actually really can help trauma symptoms. And so
That's true.
I would actually, because they're really getting at the hyperarousal criteria. So I think a history of what medicines does can be helpful if it's already there. But I mean, it actually may help you pick. I mean, you can choose ADHD medicines like the guanfacines and the clonidines and actually be very helpful to trauma symptoms. And it won't necessarily help you rule it out, but you can be thoughtful in how you pick your first choice of medicine sometimes if you think both are present, but
Okay.
that's really a complicated one. But I think going back into the deep dig, all that information is really helpful. I'll also say, and this is a different direction, is there actually is some research that was done in war on the war veteran population where they actually gave people stimulant medications to increase their focus and performance, and the stimulant trials actually made them more predisposed to be a victim of trauma because they were
Oh,
getting hyper focused. They were
okay.
missing out on other cues. So this is
Okay.
a really complicated overlay with the
Mhm.
medicine too.
Yeah. Yeah. Well, I will make sure I will change that on my slide, how I how I present that, because you're absolutely right. I don't want it to seem like I'm saying, let's put these kids on a trial. And that's not what I meant. But I just know it from my personal experience in working with kiddos, like they have tried so many medicines and it doesn't work, or they start a medication and you see a difference right away. So it's so in my practice, I've seen that piece of it. But I do agree with you with the deep dive that this I don't think we do enough of that. Not anybody here, of course. I'm not. We're fantastic, but obviously with like when I see in community mental health, right, that an intake was done that took like a half hour or maybe 40 minutes, and that's it. And then they have a diagnosis and they have a treatment plan and they have all that. It's like, really? Can you really do that in that amount of time? Because typically, I would suggest that it takes several sessions to really get all of the information. I mean, one for the parent or the child to trust you to share information with you, right? And sometimes parents are afraid if they share about a trauma history that they'll get in trouble if it wasn't dealt with. Yes, and if the child is not interviewed as well, yeah. So, oh gosh, I hope it's not just the adult. Yeah, because I mean, typically when I see kids, I bring both in together, and then I meet with the child and then with the parent at the end. So it usually takes over an hour to do that, to really get good information, and then obviously using some standardized measures like to assess ADHD in the classroom, and how that's presenting, specifically. And then looking at the differences, right? So if you have a kid who's presenting with symptoms of ADHD and they absolutely do not have a trauma history, then you're pretty clear, right? You can pretty much say, okay, I think this is the direction that we need to go in. But once you have that trauma history, it really makes it difficult to tease it out. Okay. So next slide, please. All right. So clinically, we can assess, right? We can do really in-depth assessments to figure out what's going on and continue. It's not just a one-time thing. As you're meeting with kiddos, you are and their families, you are continually assessing, right? For example, and one kid that we thought really had, and this was in a previous position, really thought she had autism. But as it turned out, she just didn't have any exposure to school settings. And so that was different for her. And so she needed time to kind of, get used to acclimate and understand how everything worked, because she was, 4 years in her home without much interaction with others. So again, looking at all of that and asking all of those questions, and yes, particularly talking to the parents and anybody else who cares for that child, so that you can get a full picture. It's hard. It takes time because, for the school, you need a release. If you're talking to a different relative, you need a release. Before, aftercare, whatever, you need releases. So it does take time to do that, but it's definitely worthwhile because you really do have a greater understanding of what that kiddo is experiencing. So how about in our classrooms? This is of particular interest to me, and I bring this in for a reason, because I really strongly support clinical services in the schools, because we have kiddos there 7.5 hours a day. We have access to them. We can work with them. So I really love the school clinical connection, and that's what we're working on to try to expand. We're at one school, but we're really trying to expand to others, because we can also work with the teachers. And teachers are amazing. They have such a difficult job. kudos to teachers because it's tough. I've worked in a school for the last school for like 6 years. So I saw all different aspects of how, how teachers interacted with kiddos, sometimes good, sometimes not. How, it would depend on the principal and what, how they saw what they needed in their school, sometimes good, sometimes not. So, but with our classrooms, we can encourage trauma-informed classrooms, right? So that way, those 1 in 4 kids who have been exposed to trauma, right? And those kids with ADHD as well, and the other kiddos in between, that if we have a trauma-informed classroom, we can help to manage both sides of it, right? So if you're going into an environment where you feel safe, you feel heard, you feel respected, right? And communications are clear, expectations are clear, we're learning how to interact positively with other kiddos, we're learning how to calm our bodies, we're learning how to use mindful breathing if we're stressed or if we're angry. So if that's being provided in an environment where a kid is present 7.5 hours a day and it's reinforced in each part of that day, for both kids who experience trauma or kids who have ADHD or depression, anxiety, this will really help to mitigate kind of those longer term effects of both ADHD and trauma. Okay. Next slide. I think that's my question. Question or comments? Thank you. Okay.
Awesome. Thank you so very much.
You're
Really
welcome.
appreciate it. That was wonderful. Very complex. Yeah, so any comments or questions? Well, saying it's great. Thank you so much, Dr. Swagger. When you're looking at, trauma, is it from just physical or is it verbal with kids or adults? Like, what is it typically that you guys find that really pushes for that diagnosis?
Well, I think with with kiddos, what we see a lot is the physical abuse, the neglect, and the sexual abuse. And I don't know Dr. Swagger's opinion, but for me, kiddos who have experienced trauma pre-verbally, like the pre-verbal trauma, that's really kind of the toughest one to address, and it can take a long time because in my approach at least, I use, the child-directed therapy because that helps them to kind of process whatever is in there that they don't have words for yet. Or so, and it's can very much be like a post-traumatic play where they may be reenacting, what they experienced, but at the time they didn't have the words for it. So I think that's the most difficult area for me. And then when you look at a kiddo who does have both ADHD and trauma exposure, right? And we have many kids who have both. It's it's really starting with that teaching that emotional regulation. Obviously, if it's ADHD, medicating appropriately, for that kiddo, but really that foundation of learning, helping that child learn how to identify and express the feelings, how to gain emotional regulation by using calming strategies, mindful breathing. It is really that foundation is very, very significant to provide for that kiddo. And then you can move into the trauma exposure, if you want to use like a TFCBT, the trauma focused cognitive behavioral therapy, or other modalities. So it can be a process, obviously.
I agree completely.
Swagger, no better.
A really interesting, thought about this, because I think your point about the pre-verbal trauma, is, we talk about sort of overlap of symptom clusters, but I mean, really at the heart of it, it also goes down to how trauma actually just is such a broad definition. And there's been a lot of arguments, especially with people that work with younger kids, that the definition of PTSD is so very limited. People have for years have tried to get more of a developmental trauma disorder that really recognizes what Kelly's saying. When trauma happens pre-verbally, you really see much more sort of hyperarousal,
Mhm.
parasympathetic, sympathetic
Yes.
tone dysregulation that's really
Mhm.
hard to verbalize, and you can't form memories when you're younger, but yet you
Mhm.
have these unexplained, unexplicable symptoms. And the
Mhm.
DSM in our diagnostic criteria doesn't really capture the full range of that
No.
either. So,
No.
you know, and I like to go back to the organic neuronal activity stuff, but you know, there's a ton of overlap in
Mhm.
pathways. And so, you know, I think we spend time teasing it out, but I think it's also recognizing that this isn't the only sort of diagnostic cluster. You have all the symptom overlap, but
Mhm.
there's
Yeah.
still treatments and there's still approaches, and we
Mhm.
have to think kind of differently about them than just sort of lumpers and splitters diagnostically. But I mean, this was a great presentation, and I think, you know, as we see, it's always messier
It
than a
is.
single thing, and that's okay.
Mhm.
I think part of it is learning, you know, I said you gotta embrace the mess, right?
We are
You gotta
messy.
live
We are
in the mess.
messy. Humans are messy.
Humans
Humans
are
are
messy.
messy.
Um, and solutions are messy too, right? It's
Mhm.
rarely one
Mhm.
magic bullet, and we got to get out of the whole there's one solution, especially with
Yes.
developmental issues, right?
Mhm.
Developmental issues
Mhm.
are going to wax and wane and change with time.
Mhm.
Just a fabulous discussion. Thank you,
Yes,
Oh,
Kelly.
thank
thanks.
you.
Thank you. And I can't agree with you more about the developmental trauma, right? That needs to, it didn't make it into the DSM-5 or the 5TR. I don't know why, because it would really help to really identify the behaviors in a more specific way. I mean, I know we have the other diagnoses that can help with that, but the developmental trauma diagnosis is really, I'm just hoping eventually it gets into the DSM, because I think that would really assist in a lot of folks understanding what's going on. And you know, it's really interesting too. I'm thinking about a kiddo that I'm working with, and when I first started seeing her, she really didn't have a lot of language, right? And so she was then engaged in speech therapy, and she was learning more. And then also, which I found fascinating, and I've seen this with several kids, when she did start medication for ADHD, that language acquisition just was like there. She was just, you know, learning more and learning more and learning more. And she has a significant trauma history, and she has a sexual abuse history prior to obviously being verbal. So it's just been so fascinating watching her development with that too, and being able to express maybe not what she doesn't know specifically, but she can express what generally is what she's feeling in her body, and that helps her then to learn how to calm. Does she always do it? No, we're still part of it because she's only 4,
Oh,
but
that's so impressive.
so we're still working on it.
That's
Yeah,
awesome.
and then you know, also she was adopted. So,
You're cutting in and out a little bit,
oh, I'm
Kelly.
sorry. So I said it can include like saying so many different things, right? And in particular, it's about attachment. And because she was adopted and she was in several different homes before age 2, so she has that overlay as well. And just working with the parents to, you know, to really kind of strengthen that attachment bond. So just so many different angles to look at, you know, to really try to solve the problems that we're faced with these kiddos to hopefully give them a good chance. So,
Absolutely. Thank you. All right, thank you so much again. Does anybody have any questions before we call it? All right. Well, I really appreciate everyone, and thank you again, Kelly.
thank
The
you.
next time we'll meet will be May 1st, and
Oh,
Dr. Swago will be doing the intersection of
yay.
genetics and psych
Ooh,
treatment.
yay.
So yeah, any questions or anything, keep those in mind. And if you need anything, please reach out, and
All
have a
right.
great rest of your month.
Thank you so much, everyone.
Bye.
Bye.